Friends, welcome to my workplace at Ranaghat, West Bengal, India. This is a very hard cataract with not so well dilated people. Let us observe management of this case. The incisions have been made. Now an air bubble is injected into the anterior chamber. Beneath this air bubble, trypan blue dye is applied over the anterior lens capsule. And now I am using two agents. One is adrenaline, the other one is phenocane from Entod. Phenocane contains tropicamide, phenylephrine and lignocaine. The idea is to get some more dilatation of the pupil, but the pupil didn't dilate much. Probably a little bit of dilatation occurred and the size of the pupil became about 5 millimeter. Subsequently, during emulsification of the nuclear pieces, the size of the pupil decreased, but at this time I am going to get an adequate sized rhexis. We can see cycle spoke-like pattern within the substance of the nucleus. I am erasing a capsular tag in this case with the help of this sharp needle, and now I am using the Utrata forceps to guide this capsular tag along the border of the pupil to get an adequate sized rhexis of about 5 millimeter. Yes, rhexis is nicely done. And now hydrodissection. As I am going to do hydrodissection, I am going to touch the iris, and the size of the pupil is going to be a bit less. I have kept a pupil expansion ring ready if it becomes necessary, but my attempt will be to complete the case without using any pupil expansion device. Nuclear sclerosis in this case is grade 5 or even more. It is a very hard cataract, and this surgery is almost unedited. The nucleus management part has not been edited at all, and this is a real-time surgery. The machine being used is Phaco's from Otley. Phaco's posterior vitrectomy system along with this Phaco with SPEEP mode. I am going to remove some superficial cortical lens matter, and then I am going to employ my technique which is known as submarine chop. Yes, for a very hard cataract, also with this technique we can divide the nucleus at on-go without making any sculpt. Here it is. The tip is buried into the substance of the nucleus. It goes through the substance of the nucleus towards the opposite equator. It goes under the surface like a submarine. It goes through the substance of the nucleus as submarine moves through water under the surface, and here it is. This is a very good crack, and I go to a deeper level and get a very nice crack. Rotate the nucleus on 180 degree and go to a deeper plane again and separate the two heminuclei completely. So this is a beautiful technique. Submarine chop technique is a game changer in hard cataract management. And this is division of heminuclei. Each heminucleus is being subdivided into 3 pieces in this case, because this is a huge nucleus. The nuclear pieces are not completely free, they are attached to each other, but I will separate it later. I come to the other heminucleus, divide it also into three pieces. This is one piece, and the other part is also chopped to get three pieces out of this heminucleus. And I get a free nuclear fragment. So my plan now is to tilt these nuclear pieces and start emulsifying. From the very beginning I am using Phaco 2 mode where the vacuum is 450 millimeter of mercury, flow rate is 45 ml per minute, and ultrasonic energy is 80% in continuous mode. Though the ultrasound is in continuous mode, I am using the ultrasound intermittently. And here it is. This is the other two pieces. Since the pupil has become small, it is about 4 millimeter now, I am doing it slowly. I'm keeping an eye on anterior chamber stability, movement of the posterior capsule, and I'm always at iris plane or just below the iris plane, and I'm emulsifying the pieces slowly using the ultrasonic energy intermittently. Yes, one heminucleus has been managed. And now I rotate and I find that this piece is free and it is being emulsified. The patient is not very old. The patient is about 55 years old but having so hard cataract. And here it is. This nuclear piece is nicely emulsified. And this is the last nuclear piece. No, the last portion of the nucleus and two pieces. My plan is to emulsify the last piece with low flow rate and low vacuum. And here is, I go to Phaco 3 mode where the vacuum is 250 and flow rate is 25 and ultrasonic energy is 65%. And it is done. So the nucleus management has been very satisfactory. And now I try to remove some epinucleus, and it is coming quite well. Vacuum is 250 and flow rate is 25. I'm in Phaco 3 mode and I come out. Now I inject bit of visco, and now my plan is to remove these cortex using a Simcoe cannula. I have made only one side port So I'm not going to use bimanual irrigation aspiration for cortical cleanup. So cortical cleanup is very satisfactory in this case. I go through the side port and remove the cortex from 10 o'clock and 11 o'clock. And the posterior capsule is very clean in this case. No cells are sticking to the posterior capsule. And now my plan is to inject visco and enlarge the main wound a bit to make it about 3 millimeter, and then implant the lens. When the pupil is small, I usually enlarge the wound a bit and implant the lens. Make it sure that the leading haptic goes downward into the capsular bag and the trailing haptic is placed in the capsular bag. And now I'm going to use this instrument. This is a wide retractor. I can retract the pupillary margin and check any cortex anywhere, or if the lens is in the capsular bag or not. Dial the lens with this instrument itself and keep the haptics about 80 to 90 degree away from the main wound. And now I'm going to remove the visco. First I remove some visco with this instrument, with this Simcoe cannula. Then I use this bimanual irrigation aspiration. First I use the irrigation behind the lens, irrigate the capsular bag nicely and remove all the visco from the capsular bag. And now when I use the irrigation and aspiration, at this time I lift the main anterior lip of the main wound and the leakage of fluid is less, the antechamber remains deep. And now this is a bit of moxifloxacin. The side ports are closed. The side port is closed by hydrating corneal stroma. A final lavage is done and antechamber is nicely formed and the case is concluded. So this is a very hard cataract and we have done it quite well. We must take challenges. We must raise the bar to improve our skills so that we can do such cases. But we must proceed slowly. We must understand how much the risk or how much chance we can take, how far we can go. Always safety of the patient and well-being of the patient should be kept in mind. The integrity of all the wounds are checked. There should not be any leakage from any side. Few drops of moxie is applied over the ocular surface and the case is concluded. Thank you very much for your attention. Always remember, wish not it were easier, wish you were better. Don't wish for less problems, wish for more skills. Don't wish for less challenges, wish for more wisdom.